So today we will take the topic on medico-legal aspects of obstetric bleeding as well as LSCS. Okay. So when it comes to all the litigations that have been registered so far regarding obstetric bleeding, 80% of these medico-legal cases are related to cesarean delivery. Okay. And then 20% of them is due to the any mishaps that happen because of any normal labor like episiotomy or any other complications that may occur during and any unfortunate complications that may occur during a normal labor. Okay, so majority of it is still arises from LSCS or cesarean deliveries. Okay, so we'll discuss all the issues related to the bleeding in obstetric deliveries or any other obstetric bleedings. Okay, so first is the consent, consent and bleeding emergencies. So usually, when the doctor is faced with a bleeding patient with no possibility or legally valid consent for the necessary intervention, the law usually will support the doctor in such situation. Okay. And any harm that is caused to the person in good faith, even without the person's consent, is not considered as an offense. Okay, if you want to save the patient and any harm that was done, any injury that happened to the patient, but it was done to save the patient, in such cases also it is not considered as an offense. Okay, and there may be certain areas which a doctor has to understand, which it makes it impossible for the patient to sign a consent, and if there is no lawful guardian available, the doctor may have to proceed with the treatment just to save the patient in good faith. Okay, so saving the patient's life becomes utmost of the patient doctor's interest, and if at all any measures taken to save the patient's life, it led to certain bleeding emergencies, the law usually supports a doctor in such cases. So there was a case of Manjulaben Vinodbhai Patel versus Dr. Harshida K. Patel and others. The patient was admitted for a MTP, abortion, and the patient had to undergo a hysterectomy following heavy bleeding. To save the patient, the uterus had to be removed. So consent was obtained over phone, and the doctor was not negligent as the operation was necessary to save the life of the patient. Okay, if the hysterectomy was not done, the patient may have undergone ejaculation, that is bleed out and die. To save the patient, hysterectomy had to be done. Okay, so here also in this case, there was no compensation or no charge that was filed against the doctor here, because whatever was done was to save the patient. Okay, bleeding in first trimester. Usually, one is warned not to declare a woman pregnant or get a positive urine on getting a positive urine pregnancy report. So even when the patient has done the test anywhere else, and the urine report tells nothing about the viability of the embryo. Only an ultrasound can declare. Okay, ultrasound is considered as the better tool to understand the viability of the fetus, where the fetus is present, and is the fetus viable or not? Can the fetus survive the entire course of pregnancy or not? Okay, so ultrasound will give you clues towards any other litigogenic complications, such as if it is an ectopic pregnancy. If it is an ectopic pregnancy, it has to undergo abortion because the woman's life will be in danger. Ectopic gestation, disappearing twin syndrome, gestational thromboplastic disease. These are some complications of pregnancy. Okay, in such case, any anencephaly, the child who has not achieved the proper closure of the skull or the spinal cord or the nervous system. Okay, those lead to anencephaly. So on all these cervical pregnancy, it is a very volatile situation, and if at all a bleeding is taking place during because of these complications, it has to be registered earlier. Okay, in the first trimester itself, it has to be registered, and if the patient wishes to go through go along with an abortion, it has to be supported. Then illegal abortion. Bleeding and other complications after an illegal abortion are major cause of maternal death, specifically if it is done by an unqualified practitioner, a quack, or someone, okay, who does not have the history or training or proper skill or training or surgical training of doing an abortion, but still this person may perform abortion. They are considered as quacks. So if at all anyone who comes across a patient with a history of an illegal abortion done, for example, after illegal abortion, continuous bleeding may take place, and the patient may go and see another gynecologist or obstetrician, and from what it sees, if they understand that okay, abortion was done, illegal abortion was done, in such case, the doctor has to inform the authorities that an illegal abortion has took place. Bleeding in an illegal abortion can be due to the following causes. Either it is a trauma, infection, or incomplete abortion. Okay, some parts of the fetus may have retained back in the uterus. Okay, so in such cases also, it is mandatory for doctors to report all the confirmed or even suspected cases of illegal abortion has to be informed. Late trimester bleeding. Major causes of late trimester bleeding are for conditions like placenta previa, abruptio placenta. Okay, and how do you understand this? How can you diagnose this? It's only because of the ultrasonography you can come to conclusion of these situations in pregnancy. And usually, last trimester bleeding may take place if a woman has placenta previa. That is, a placenta has been attached quite low in the uterine cavity. Okay, so it is a risky. It's a very risky pregnancy. So the importance of ultrasonography scan cannot be overemphasized during the entire course of pregnancy. Whatever diagnosis has to be done, ultrasonography scan reports are the foundation of it. Also, it is important that the communication is made to the patient and or her relatives about the potential seriousness of these conditions. Okay, and what kind of participations they have to do. Usually in placenta previa, the proptiated placenta, woman is suggested to have a complete bed rest throughout the pregnancy, not to strain and do any straining work. Okay, abstinence from sex, and avoid all the even using stools to reach any height or something like that has to be avoided. Also, an attendant should be there with the pregnant woman at all times. So these all are the management one can guide for a person who has placenta previa or abruptio placenta. And documentation also has to be done about what all health education and guidelines or management ideas you have provided to the patient. Put it down in documentation and make sure that the patient or the patient party signs it. Patients with rare blood groups. So availability of blood is a very tricky issue, specifically when it comes to rural areas. So medico-legally, it means that the patient should understand the risk of blood transmission during the pregnancy, okay, or during the labor as well. And they do agree to donate the blood, like a donation from the patient for another patient, okay, and participate in her own care. Even though obstetric hemorrhage is very severe and mostly unpredictable component of healthcare, okay, but blood has to be kept ready for all the labor, all the labor that is supposed to take place, just to be careful. Okay, better not be sorry than late. Okay. Then you have mismatched transfusion, in which in case of any morbidity or mortality results from transfusion, the protocol for investigating the transfusion result reaction should be meticulously followed, because it may have caused already some harm to the fetus as well if you have given any wrong blood to the wrong pregnant woman. All samples of the patient, the blood bag samples, transmission set, etc., will be the sources of information. It will be used as proof, for the proof as well. Vaginal birth after C-section. Whenever a patient is being allowed allowed a trial of labor with any scarred uterus, or the operation theater should be alerted, because if anyone had a past history of C-section, definitely uterus will have a scar. Even though it is an incision, it is a scar. The second time she gets pregnant, and if she is going for a labor, okay, it means that the uterus already has scar. There are high chances that the scar may erupt. Okay, so that is vaginal birth after cesarean. The operation theater should be alerted. Keep everything ready. Equipment should be checked. Blood should be kept ready, because it is a high risk pregnancy. Okay, you had a history of cesarean section, and post which you are still going for a vaginal birth. You are trying to have a vaginal birth in the second time. You come under the high risk category. Protocols for induction and augmentation. Induction of labor, that is, you have to give the oxytocin medication will be given under guidance. Okay, misoprostol, and under proper investigation, only 25 mg dose is accepted for induction of labor at term. Only when the woman has reached term, labor induction will be started. If she is getting delayed, if the due date is getting delayed by 2 weeks, 3 weeks, or so on, so in that time, induction of labor is done. Then obstetric hysterectomy. Torrential bleeding is not amenable to any other surgical method of hemostasis, which land the patient into an obstetric hysterectomy. The decision should be taken by consent. Consent from the relations also should be desirable and valuable. But it is only possible in dire situations that you are planning for an hysterectomy, emergency hysterectomy, after any obstetrical processes. And also, an obstetrician is expected to use their fair sense to decide and execute the decision in order to save the life of the pregnant woman. Okay, if only it is a life-threatening condition, you may have to undergo an obstetric hysterectomy. Otherwise, you have to try all the other methods to save the uterus as well. Then death. Maternal death leaves everyone concerned and shattered, and it has to be reported, and post-mortem has to be insisted upon. So there was a situation in which Dr. Ravindra Kulkarni versus Balasaheb Gangaram Ghawade, in 1999, a case was registered. So allegations made here was the non-attendance after delivery, which led to the profuse bleeding and death were made in this case. So the district forum held that it was a case of abortion, dilatage, and curettage, and compensation was also provided to the aggrieved family. Okay, after this abortion, profuse bleeding was there, but soon after the procedure was done, there was no medical care or aid given to the patient. Okay, the patient was left to bleed out to death. Okay, so that was so this here the in such cases compensation will be given. Okay, post operative care, if it is not given, compensation can be given. Next is medico-legal aspects in LSCS. LSCS stands for lower segment cesarean section. Okay, lower uterine. Okay, lower uterine segment cesarean section. It is the other name used for LSCS is cesarean section. Okay. So it is one of the most commonest operations conducted in OBG practice, and with years, the rate of people who are choosing for LSCS is increasing day by day. Okay, because of several reasons, like women who are becoming mothers at a very late age are more likely to undergo LSCS. Okay, like after 30, 35 and all. Okay, high risk pregnancies, or mothers who are of a specific age. Okay, they usually go for LSCS. Larger babies, especially in mothers with diabetes or gestational diabetes, it is the most common feature to go for LSCS. Better monitoring, it leads to pick up fetal distress earlier if the fetus is distressed. For example, meconium in the amniotic fluid, or the child has swallowed some amniotic fluid. In such cases, it is easier to understand through an ultrasonography and then make a sound decision. And also, a reduction in mortality and morbidity has been reported when it comes to LSCS rate. Fear of litigation prompts obstetricians to take less risk, resort to LSCS earlier in high-risk situations. So these are the reasons why more and more mothers are going for LSCS. So what are the most common issues that we face in cesarean section? The most common and the most prevalent issue is associated with bleeding. Okay, but this can be avoided. The situation can be avoided if the healthcare team is very vigilant about the possibility of bleeding in all cases of cesarean sections, and you send for blood for cross matching in all cases of C-section, so that the blood bank is alerted, and you and even if it is at a very far away distance, you do make sure that adequate amount of blood packs are available if at all there is any emergency. So in that way you can mediate this particular situation. The second most prone to litigation area is vaginal birth after C-section. VBAC is vaginal birth after C-section. So again, here documentation should be able to prove that labor was meticulously monitored. There was no fallback from the healthcare team or hospital side. OT was also kept ready for emergency C-section if it was necessary. Okay, and there was a case of DK Nayak versus Dr. Kalyani in 1997. Because blood was not arranged in spite of the fact that the blood group was rare for the case of C-section. So in this case, 2.35 lakh compensation was given to the complainant by the hospital. The third area is about the qualification of the person who is performing the LSCS. Okay, ideally the C-section is expected to be performed by a gynecologist, and if the general practitioner with just an MBBS degree or a surgeon with an MS degree does the C-section, they have to produce proof in the court that they have undergone the training for this particular surgery. Okay, also further proof is required that the gynecologist was not available for a particular surgery, and to save the patient's life, a general surgeon or an MBBS graduate with a proper training had to do the C-section. The second area of questioning would be the infrastructure. Did the hospital have a well-equipped infrastructure? Did it have all the essential equipments like oxygen cylinder, Boyle's apparatus, defibrillator, in case if it is necessary? Is all equipments sterilized or not? Okay, the infrastructure wise, all the checklist has to be ticked properly. Expiry dates of the drugs, oxygen cylinder filling dates, maintenance of the other equipments. Okay, these standards should be followed, and what kind of drugs to be used, anesthesia to be used, disposable. Okay, what is available in the OT, you have to make sure infrastructurally the OT or the room is ready to take on a LSCS case in emergency. The third question is regarding the pre-operative precautions. So there is a pre-operative questionnaire or a checklist to get the proper history of previous surgeries done by the patient, conducted on the patient, medical problems that the patient already has or is going through. These all details are filled up by resident doctors. Blood cross-matching, hemogram, BT-CT, the urine examination. Okay, these should not be ever missed. Documentation is important that all these tests has been done. You have ruled out any complications, and successfully you have chosen to go forward with cesarean section. So documentation should support you. And also after LSCS, you have to still continue the documentation of how the mother is doing, how the fetus is doing, was there any case of fetal distress, etc. Apgar score of the fetus, all these things has to be documented properly. And certain issues regarding consent is, for example, consent was taken under pressure. Okay, what the seriousness of the situation was not explained properly to the patient or the relatives. So these kind of examples do come across. Consent of the patient herself is also important. If the patient is not minor, consent of the patient should be taken into account as well. And if it is a minor, or if it is a patient who is insane, who is going through some mental health issues, in that case others can sign as a witness. Detailed explanation has to be given in the consent. What kind of treatment is this, benefit of this C-section, possible side effects or complications, available alternatives, consequences of refusal of treatment. If you do not do this, go forward with LSCS, what may happen to the child or mother. Antenatal, even in antenatal classes which the patient have took, okay, before during the various trimesters, all these issues can be discussed there also, not to frighten the patient on the day of labor. She should be well prepared for vaginal, and if it is not possible, to go for emergency C-section. So if the patient knows all the pros and cons of this way earlier, she can make a sound choice. So while giving consent to LSCS, it does not imply that you have given consent to other procedures like appendectomy, hysterectomy, etc., until it was a life-saving step. Okay, for example, certain cases have took place when the patient was not aware that she is having some chronic appendicitis, but during C-section, it was seen that the patient is suffering from chronic appendicitis, which may spread, cause further issues in the future. To save the life of the patient, the doctor can go ahead and take the appendicitis out. Okay, but otherwise, generally, just for the sake of taking the appendix out, it is not suggested. Consent can be taken by resident doctors as well, with proper, only if you want to do any other associated procedures like tubectomy, appendectomy, it has to be mentioned. For that also, it has to be mentioned. The patient should be aware of it before going under anesthesia. So that's about medical legal issues in obstetrics and gynecology. We will discuss later.